Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice. In any situation, please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you are unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hi guys, welcome back to another episode of Glasses Half Full. Thanks for joining us. Today it's the very important topic of Paediatric Optometry. Huge topic, not the only episode we'll be doing on it, and hopefully we'll get some experts in as well. But today it's a rather brief overview, and in particular, something that you as patients, practitioners, parents, you can consider when thinking about making sure that your children or your colleagues or whatever it is, your patients, are coming for their routine eye checks. It's often the case that you see random first tests, whether it's a 9-year-old coming in, a 6-year-old, 3-year-old, even like a 45-year-old. Sometimes you can be surprised that, oh, I've never had a test before. And it's just really important that we make sure people are coming for their routine checks.
Yeah,
and the 45-year-old for his first test will have large oblique sills.
Yeah, of course.
That is just an unspoken rule.
That's it, definitely.
They'll come in with 250 sills
and a handful of ready readers.
At 50 and 140.
Yeah. So oftentimes, as practitioners, when it comes to kids, I wouldn't say there's a lot that can go wrong, but there's a lot that can go wrong with any age.
Yeah.
One thing, at least to me, comes to mind first is binocular vision problems.
I think the main thing with under 16, more under 8 testing is binocular vision.
Well, the main atypical thing.
Exactly.
Yeah.
The main thing that you're making sure that you want to not miss, especially when they're under 8, is
you don't want to miss anything, but it's...
Yeah, but the thing that when...
has the biggest potential to
Exactly.
cause lifelong problems.
Exactly.
Or just
if the vision's not good and if it's not equal.
Yeah, basically.
But it's also the most common. Like, how many... Like, under 8, when you think about how many referrals you do, how many...
The most common sort of pathology that you'd see in an under 8 patient would be a binocular vision issue. Not all of them, I guess, are as serious as each other. But usually it's a binocular vision issue that you get. I mean, you get the odd toxoplasmosis if you ever see it.
I've seen it once
in a career.
BV is the most common one.
BV is the most common one.
So it takes through Mehdi. What type of BV issues would you see?
So the main risk is amblyopia, which is what you're concerned about with a patient with a BV issue to develop. So amblyopia is the fancy term for lazy eye, as everyone should hopefully know. And basically it's when one eye is weak to a point where the brain basically ignores the vision through that eye.
Or both. I've seen a fair few bilateral amblyopes.
Bilateral, yeah.
Fair few.
Goodness. That's not good.
Mine is 16s, first eye test at 12.
But that's essentially when the vision in the eye, or both eyes in your case.
As in it's one family where a lot of the family members
it's when the brain doesn't develop that link to the eyes as well. So the VA that you achieve with the eye is not optimal. So you can get amblyopes that actually end up being 6-7.5, which again isn't optimal, but you could class them as amblyopes. You can also get someone that's counting fingers. There are different types of amblyopia, which I'm guessing people do know, but I'll go over them.
Before we go into that, sorry. This is pediatric.
Yeah.
Okay. Highlight the importance of why amblyopia is important to target now, and not when they're 9 or 15.
So plastic period is the fancy name for it. Basically,
don't call it that fancy.
Fancy name for it. Up until about the age of 8 is when the binocular status of the eye is relatively malleable, so you can kind of mold it into shape again.
When you
That's how I like to say. Yeah, when you can fix it, basically.
Let's hope.
Hopefully you can fix it.
It's never a fun conversation.
Once you reach around 8, above 8,
sometimes 9.
Yeah,
roughly.
But the prognosis is nowhere near as good as when they...
Oh yeah, starting patching at 9 isn't going to be good.
Yeah, but once you reach around 8 above, what you have in terms of binocularity is what you get. You can't really change it after that, unless it's something that develops after that point. I need to do treatment to bring it back to that point. But in terms of the because the main thing with amblyopia is you don't have the stereopsis. So because one eye is weak, it's to a point where the brain cannot fuse the images of both eyes together, so you don't get stereopsis, you don't get that depth perception, and that's basically what the amblyopia is.
I'm gonna go against the grain here.
Yeah.
I don't think the loss of stereopsis is, and this may be recency bias because of literally one of the last patients I've seen. I don't think the loss of stereopsis is quite the biggest risk factor. Yes,
it's not, but it's something that can affect someone's career paths, obviously, and B, it's more the fact that you're using one eye than both eyes when you could be using both eyes.
Yeah, and the risk is obviously you don't know what's going to happen for the rest of their life. They could have a freak accident tomorrow and fall on a pen and their right eye is suddenly gone, and all you've got is 675 instead of
but
6.
Stereopsis is generally in my opinion, one of the best ways to measure binocularity, because that's
it's the objective measure. It's the only real way to measure how well both eyes work together.
Measurable way.
Yeah.
Because you can have someone who does not have, well, I'll get into it in a second, but someone who does not have a strabismus, so a trophy or something, but also does not have stereopsis.
Yeah, of course.
So you can get that as well.
Yeah.
But stereopsis is I think, the main marker to check for amblyopia, because if someone doesn't have stereopsis, then they don't have that perception, which means that the brain isn't fusing the two images, and you need to find out why that's not happening.
Yeah. So it's either because the images aren't aligned in the same place because of atropia or aphoria, or because one image isn't as clear as the other, which is either going to be.
So there's a couple of different three different ones basically. You have the strabismic amblyopia, which is the common one, which is tropias basically. One, and then you have the meridional one, which is
biggest stigmatism.
It's biggest stigmatism, or I think it's just general.
Yeah, like a difference in the
difference in the stigmatism basically, and then you have the anisometropic one, which is one of the more common ones.
Yeah.
Which is basically one eye has a higher prescription, therefore it's.
You can also have a physical obstruction.
Like congenital cataracts. Yes, that's right.
Congenital cataracts or diatosis of.
Definitely, yeah.
I can't remember whether I saw this myself or I think I did see it. Sorry, yeah, I saw this patient who had a surgery because the eyelid on one eye was sort of shut when he was born, and he couldn't open the eye. And when he was about, I think 4 or 5, he had a surgery to open it a bit, and another surgery again at 10. But they were patching him like crazy in the meantime because it was he had no vision at all for the first sort of 2 or 3 years of his life. Yeah, I mean, it was still amblyopic to some extent, but it retained a lot of vision. Serviceable somewhat, yeah.
I had a patient earlier today, and she was elderly and in the early stages of developing cataracts.
Yeah.
She was very amblyopic in terms of just needing a balance lens in the contralateral eye, and it was a case of really being hesitant as to even approaching the discussion of cataracts because, like, no, we can't risk an operation.
Yeah.
Like, we can't, like, she was seeing 6/6, and it was a case of I just saw, a slight amount of cloudiness. Like, we don't need to worry or be concerned about it at any point in the near future, but this is something that someone may bring up, and you can just let them know that you're aware of it. And yeah, that brought up a whole host of
can of worms.
Can I do it? Will I do it? And it's like, operations are operations, and all surgeries have risks, but at a certain point, you might be fine with your husband driving and all that stuff, but we can't just keep letting it.
How old was this patient?
I think late 60s.
Oh, okay. So
early
senile cataract, basically.
Yeah, absolutely.
Yeah, I've seen. I think once on a previous occasion there was a patient who had a whole host of health problems. So they had like DMO and stuff like that, and one eye was amblyopic, and they needed to do cataract surgery. So they did one cataract surgery on the worst eye as a trial run to see how the body would respond to it before they did the cataract surgery in the good vision eye. I mean, it wasn't terrible vision. I think the amblyopic
was this patient request, or was that what the hospital decided to do?
I can't remember. I saw the patient post-op.
Okay.
So all I had was the notes of the previous hospital letters. But the hospital said basically we're going to do a cataract surgery in your worst eye at 6:30, probably best correction post cataract.
Yeah.
and then once we see how your body reacts to it, whether you're going to have a very sort of inflammatory,
like edema or anything.
edematous response before they did the good eye. Because when you think about it, it is a lot of money to obviously pay for 2 cataract surgeries, but hypothetically, imagine the patient wasn't amblyopic, they would still be paying the same amount. And 2, if you know how the surgery is going to turn out in terms of post-op complications, you can minimize the risk and you can mitigate the risk of serious post-operative reaction to the good eye, which is a situation that nobody wants. That's the worst situation, isn't it? You've lost an eye post-op and you're left with an amblyopic eye with a cataract.
With enough resources, you could you'd love to do that on most people.
Well, yeah, to have trifocal IOLs at 30.
Yeah, like with enough resources and time and effort, you love to do a lot more than what is actually able to done. So good for her to actually being able to get that.
Yeah, it was really good. The patient was happy at the end of it. They said, I'm glad I had it done because I can see.
Yeah, yeah. It's always good. It's always good to see. So amblyopia.
Yeah.
And how do we prevent that? How would you test for that?
Okay, so the main tests I would personally like to do is your visions and your VAs.
It's always a good place to start.
Always a good place to start. Because with that, you'd obviously notice if there's a visual disparity.
You're going to do history and symptoms first?
Yes, but you do that on every single person. But this is like specific.
Divisions on every single person.
This is specifically for what I'm expecting to see. Like
we're assuming a 4-year-old kid.
Yeah.
Sure, you'd love a family history of both your parents are amblyopic and you have 2 siblings who are both amblyopic.
I mean, I would.
And it was both the right eye. It was always this side.
Is there a link?
No,
Okay.
I think there might be an amblyopic link.
No. Between which eye it is.
Oh, I don't know about that.
But,
yeah, I've had patients come in and tell me, I know it's my right eye, and I know it's his right eye because I've got it, and his uncle's got it on his right side as well. So our family on the right side have always had problems.
Was it on the right side?
I don't know.
Okay. It probably was.
Probably was.
50-50, if anything.
50-50.
But yeah, you have your visions, you have your cover test. I really like stereopsis tests. I always do that.
What's your favourite stereopsis test?
Well, I only have titmus fly, unfortunately.
Right, me too.
But I would like Lang because that's a bit easier because you don't need to. The patient doesn't need to wear anything. Then they're just looking for pictures.
I like it when they wear something because it makes them feel excited that they've got these
True.
big sunglasses.
Yeah,
on.
I call it like a game.
And they're always too big. Yeah.
But I feel like with Lang, because in my previous store we had Lang tests, and I feel like especially the younger kids, they were more responsive to that because they try and find what it looks like. But with the titmus, they kind of lose a little bit of patience if they're trying to look for something that's quite small in terms of the seconds for
I mean with kids is again you've got a massive focus problem because they're 4, so
basically
it really is a case of do as much as you can,
but
as quick as you can
exactly.
in any order, and then start thinking about putting notes.
But yeah,
on.
so if visions is fine, if cover test isn't finding any tropias, and the stereopsis is at 60, I'm all right.
Good equal visions.
Yeah,
and asymptomatic is my.
That being said, even if visions were obviously not because obviously if the visions aren't equal, if the visions aren't equal, the stereopsis is not going to be there anyway. So usually, okay, you tell me a 6'10" right eye and a 6'5" left eye is going to.
Okay, when the discrepancy is that different, like
no.
But then how is that amblyopic?
I'll show you a 6'10" and a 6'5".
Because
malingering.
They'd be high risk of amblyopia if they're underweight, but they would be amblyoppic if it's past that
6'10" is best corrected, the other eye 6'5". What more are you looking for? What more information do you need to discern?
You don't need more information. Yeah.
So you wouldn't even attempt stereopsis?
Not at that point.
Yeah.
No.
Okay.
Yeah, but it's when those markers come back as okay, then I do stereopsis. I'm like, let me just make sure that everything is fine.
So say there's 6'5" in both eyes, but they got no stereopsis. Would you do that?
I would probably cyclo refer, because it depends on if they're compliant or not.
If they've got 6'5" in both eyes,
it depends on their age as well. If they're like 6,
I would just assume that depending on how it.
If they're 6 and they're not able, then I would probably cyclo refer because your window is lower.
The space between the word cyclo and refer was very quick there. That's a big part of it. You do a cyclo, you figure out what the RX is, and then you.
Well, yeah, but when I say cyclo, I'm fine. I'm not going to just put drops in. I'm like, okay, I'm going to refer you.
Yeah.
You don't just put drops in and
But
let
you
them
do
go.
cyclo to find out, oh, hang on a minute, they are an azimutropic, and that's why it's reduced.
Well, yeah, but I would
In which
still
case you
refer.
prescribe and then you monitor in 6 months' time.
I would still prescribe and refer. That's because it's a surefire way. Unless I'm 100% sure that I can manage this patient, I would be referring to the hospital still.
It would take a lot to convince me that the patient just isn't bad at the test. If they're 6'5", everything else has gone well.
Yeah, if they've got a minimal prescription, there's 6'5",
It depends. It very highly depends on the compliance of the child.
As in, I'd probably reattempt it with glasses on collection, because oftentimes they come in.
I tend to just refer it.
Mucky lens.
I feel like
I'd go further than that, because especially if it's first time, they're going to need time to adjust and adapt to the glasses. I'd probably put on a 3-month or 6-month before I'm starting to refer.
But yeah,
I mean, refer if there's any. And if they've got a bigger ISO and they've got the thing and
the thing is,
they might need patching. Refer.
Purely because I don't feel overly competent to completely manage BV issues that have a risk of amblyopia. I feel it because it's the safest way.
You don't give out patches.
No, I do atropine drops.
I missed that. Now what's in my bag?
Patches. No.
Patches. Yeah.
But yeah, purely because I don't feel like I'm overly competent enough to manage patients, especially patients that are like 6, 7, like getting to that end of the plastic period. I am more than happy, and I feel like it's just best practice in my own clinical expertise.
Depending on the patient.
Yeah, just to cyclo and refer, because then I know that they're going to just be seen at the hospital and managed to the best of the ability there.
Would you be more or less likely to refer with urgency when they're approaching the end of the plasticity period?
It kind of depends. Usually I'd probably be more, with urgency, I'd probably be more urgent to refer if I'm finding something.
Yeah, because even
it's 3
months makes a big difference at that point.
Exactly.
You only talk about 1 or 2 years, even 3 months.
Exactly.
Yeah, I've done urgent before.
Yeah.
Like
the thing,
a 6-year-old with a bigger ISO.
When I get like a 7.5-year-old kid, I'm just like praying to have equal VAs. I'm just like, please 6'5", please 6'5".
Okay.
But you can read that. No, I can't. Yes, you can. Read it. I'll tell you what it is.
Get closer. Get closer.
Just come out. I'll make it bigger.
But yeah, maybe if they were, let's say, like 4 years old or 3 years old,
you got more time to.
Yeah, like I can prescribe, put them on a 6-month recall, check how it is, and if it's not changing, then I'm referring. Do you know what I mean? But when it's getting to like 6.5, then I'd be like, you know what? I don't want to risk missing anything, and I don't want to risk wasting time. So I'm just gonna cyclo, prescribe, off you go. That's it.
I definitely am a lot more trigger happy with referrals when they are getting a little bit older and getting more.
Yeah.
And also as a locum, I don't know what tests will be done when they come back. So I'm a bit.
Do you look at because the practice that I work, most of the tests are either done by myself or my colleague. So I always look at the previous notes, and if there is any special requests for repeat cyclos or repeat visual fields or repeat IOPs in this time, I'll always make sure I do those tests. Is that something that's done commonly?
I wouldn't see why.
Would you always look at the previous notes?
Because
I've had locums work with me, and they've said, I said to them, "Oh, did you check the previous notes?" Because I put some notes on what to do.
Yeah.
I said, "Oh, I didn't look at it."
No, I with honestly, if they've been here before, I always check their notes previously, because I'm like, let me just see how they did in the previous test, and
so
then
you know what to expect.
So I know what to expect. So
as if they were reading 6.5 before, but 6.12
and then I'm saying 6.20, I'm like, there's something wrong. But I've never actually had a locum put in the notes saying cyclo next time.
Or I've had that.
You probably should.
Or I've had that. I had
I'd
one.
be like, go do it yourself.
Exactly.
Yeah, I had one that was like 6 or 7, but I mean the kid was just completely non-compliant.
Yeah.
Whatsoever, and he came in saying he was having headaches and he just wasn't reading anything. The autos were like next to nothing.
Yeah.
And they put him on a 1 month 1 month recall to review. I thought to myself, this is a cyclo. This patient definitely came in at 4:30, didn't they?
Yeah.
Cut that out. It was Catherine. Cut that out. She's lovely.
Things like that, I feel it's a case of lack of practitioner confidence to a certain extent.
To some point.
Like when I see a 1 month recall.
Yeah.
To be fair, the 1 month said one eye was slightly reduced. Consider cyclo at next appointment.
Next appointment in a month.
Yeah.
Sometimes
I think to be fair,
if
they
let's
prescribed a 150 and a 2 when it was really 2 in both. So the 150 was 6.9.
if they're let's say like
It just
4
wasn't
years
refracted
old,
properly.
they've got 6.5, and then stereopsis is like 100 seconds. I'd be putting
4. I'd be 6 months.
I put them on 6 months because I'm like, okay, if they're a little bit non-compliant or something, I'll double check to make sure that they're going back.
100 at 4 is pretty decent.
No, they need to be 60. Mate,
60.
after 6 months, their stereopsis normal.
Yeah. It's not okay.
No, so develop 3 months.
It's not.
Yeah.
It's not. It's about the patient more so than what their eyes can see. Most of what we do is subjective.
Yeah, but stereopsis
It's still a subjective.
should be
test.
yes, but it should be at 60 seconds. After about, I think, is it 6 months?
Yeah, depending on the kid, you could have 2 kids with exactly the same stereopsis. One's going to come out with 120, one's coming out with 60.
Yeah, compliance. I'm not talking about
but
compliance.
that's as large a variant as anything else, and you can't just be like, oh, not every kid is 40 at the age of.
No, but 60 is normal. So anything that's below 60 is a concern.
Is abnormal either stereopsis problems or lingering
Exactly,
or inability
which is
to
why I put
test.
them on 6 months, because I'm like, maybe when they're a little bit older, they'll be a bit more compliant with it. That's why.
Okay, yes.
Not necessarily because I'm concerned that they're going to have a stereopsis issue, but because they're both 6'5", I'm like, yeah, it's probably just them being a little bit non-compliant or not wanting to push themselves a little bit.
Okay.
So obviously we want to avoid having an amblyopic outcome in all BV problems.
Yeah.
What are the other non-detrimental to life choices?
Non-amblyopia possible.
Non-amblyopia outcomes that you
Yeah.
can have in these situations with BV problems.
Well, I guess the other ones that we are about to mention, it's not necessarily child specific that we're concerned about, but one of the things that are very common in what I've seen in practice, and I think is actually quite common generally regarding BV issues, is convergence insufficiency.
Okay.
Especially with kids that do a lot of like up close work. So
As they do nowadays with the screen
with like the
times and things,
iPad and the laptops and all of that. So that I think is probably the most common, which easy fix, pen exercises. The only problem with that is that not everyone's compliant with that.
Yes.
So some things that you might want to consider is whether they're myopic. So not push the minus, obviously, but giving a myopic prescription because of ACA ratio
to induce more convergence.
To induce more conversion can help to relieve convergence insufficiency. But the best method is the pen nose
Obviously,
exercise.
better to strengthen the muscles than to rely on RX.
Another thing that I would say would be not as common, but also there, accommodative insufficiency is another BV issue, which is quite difficult to, I guess, diagnose or find out because it's not very evident. But it's generally people with essentially presbyopia symptoms, but when they're quite young, generally speaking, because their accommodation is less than what it should be. So you'd probably get the whole, well, my reading's not as clear, or it's blurry, I'm getting double vision with reading, strained eyes and that kind of thing. And then what I've noticed is when I correct the distance prescription, the reading is still not very affected. When you put a couple of plus lenses for the reading, it improves it a little bit. But the easiest way to rule that out is your RAF rule and doing your blur point.
Measuring
measuring the accommodative
amplitude of accommodation.
Exactly, yeah. For that though, you'd refer it.
Oh yeah.
Yeah, so you'd refer that one, and then they would probably. I don't think there is any actual fix for it.
Varifocals.
Yeah, literally.
At
I think
age 12.
bifocals as kids. I actually dispensed a bifocal to a 10-year-old.
Yeah, I saw one on collection.
So it's not something that's unheard of, and it is something that's possible to be there. But I guess they move on to the bifocal era quicker, and also the kids always have the executives. They don't really have anything else until they're like old enough to know.
Any particular reason why?
Just because they have more of the regions, because kids tend to not be very
good at holding something specifically.
Exactly,
They
in the
want to
right
be able
area.
to move around and
So executives tend to work the best, I think, when they're more compliant and they think about maybe other forms of correction with multifocals. But they're the two BV things that I tend to see, that I have seen. One that I've not seen would be like nystagmus in people with like ocular albinism.
Not seen much of that, yeah.
But you'd refer
I've seen
that.
3 or 4.
Have you?
Not diagnosed, but I've seen.
But you've seen them.
Yeah.
What, they were undiagnosed or they were?
No. I didn't diagnose them. They already.
Like they were.
Long time. Oh yeah,
hard
of course.
to miss.
Yeah.
Was the nystagmus though in primary position, or was it when they're looking around?
Primary.
Primary as well.
I mean, sure, it got worse, but also when they're looking around us further into the test.
Yeah.
So they're tired.
So yeah, exactly, the fatigue test,
Yeah.
etc.
But I guess that's something that you could look, because with ocular albinism, you don't necessarily get someone that looks like they have albinism.
Features.
So
yeah, all the ones I've seen were very typical albinos, but yeah.
okay, but because you can have just ocular albinism, can't you? So like your iris can look normal.
Not going to be brown, but
no, you can still get brown.
really,
Yeah,
wow,
you can still get
So
brown
really-
people.
So how
but
does it present?
well, you'd have the other symptoms for it. So obviously you'd have like the nystagmus and things like that. But ocular, like the actual eye can still be brown with an
Okay, so it
yeah.
does not look like
Well, it's the
albino at
it's
all.
the iris epithelial pigment that's missing. But you can still get brown.
Is that where you
Eyes.
see the iris transillumination?
Yeah, so they still be brown, but when you
But then when you shine through, you can see the gaps in the
you
iris.
can see the transillumination from the iris because the epithelial pigment's what's missing there. So that's ocular. So you don't necessarily have the hair and the skin being pale, or lack of pigment there.
We will be going into more depth on a lot of this topic because it's just so much of our
Probably be quite a lot of overlap as well.
career.
Yeah.
No, of course. But thanks for joining us today, and hope to see you next time.
Thank you.